Good afternoon. Today I will speak on live over the dark side of colloidal anastomosis. Rather than focusing only on leakage prevention itself, this talk will concentrate on how pelvic complications become chronic, how function deteriorate over time, and what practical service strategy can interrupt that course. There is no disclosure. The outcome of colloidal anastomosis should not be defined only by technical completion in the operating room. True success requires oncology clearance, absence of chronic sepsis, and acceptable functional quality of life. In ultra-low reconstruction, even a small early problem can translate into major long-term morbidity. So success should be understood as long-term stoma-free survival with tolerable bowel function. Let me illustrate this with a representative case. After laparoscopic TME, colloidal anastomosis was performed without intraoperative problems, and the patient was discharged uneventfully. However, pelvic pain and discharge developed later, and the patient was readmitted. Eventually, chronic presacral sinus and stricture developed, accompanied with severe loss. This case demonstrates that even technically successful surgery can evolve into functional failure when chronic pelvic infection persists. This progression follows a time-dependent pathway. An initial insult, such as leakage, abscess, or ischemia, may appear minor at first, but if it persists, it evolves into chronic pelvic sepsis. Structural sequelae such as sinus and stricture follow, making stoma reversal difficult and leading to long-term functional impairment. Therefore, preventing the transition from acute to chronic disease should be considered the primary objective. To approach this systematically, 3 interconnected pillars should be considered: safe construction, early recognition before chronicity develops, and preservation of acceptable bowel function without the stoma. These elements should not be viewed separately. Decision-making, surgical technique, and postoperative rescue must function as one continuous strategy. With that framework, the first practical step is designing reconstruction with quality of life in mind. The key question is not simply whether reconstruction is technically feasible, but whether the expected long-term function will be acceptable for that individual patient. In very low reconstruction, decisions at the anal canal can broadly be categorized into proceeding, staging cautiously, or reconsidering reconstruction. Favorable sphincter function and tissue conditions support proceeding. Borderline healing conditions, especially after radiation, may favor staged approach or diversion. When total intersphincter resection is required or functional outcomes are predicted to be poor, reconstruction itself may need reconsideration. Key considerations include intersphincter resection extent, radiation history, and institutional experience. Even after reconstruction is selected, functional outcomes differ according to reservoir design. Straight anastomosis is simple, but often associated with early urgency. J-pouch can improve early function, but required sufficient pelvic space and colon length. Side-to-end reconstruction is frequently feasible even in a narrow pelvis and provide acceptable function. Coloplasty has been explored but carries concern regarding leakage risk. Ultimately, reservoir selection should balance anatomy, perfusion, and functional goals. From the patient perspective, success is defined not by technical perfection, but by daily life. Stool frequency, urgency, clustering, and continence directly influence quality of life. Chronic pelvic sepsis is closely associated with permanent functional deterioration. Therefore, preoperative counseling that established realistic expectations is an essential part of treatment. Once the design has been determined, achieving the intended results depends on safe construction. The operative plan must be translated into an anastomosis that withstand the physiologic challenges of the deep pelvis. Ultra-low anastomosis can be considered a final technical challenge because multiple constraints coexist. Reach is limited in a narrow pelvis, distal vascularity may be borderline, and tension-free alignment is difficult to maintain. In addition, sphincter preservation and nerve protections are essential for long-term function. These factors reduce tolerance for even minor technical shortcomings. Intraoperative risk often occur simultaneously. A borderline perfusion, residual tension, mesenteric twist, and small technical defects can interact to produce significant complications. Patient factors such as prior radiation or frailty further amplify these risks. Therefore, surgical standardization should be designed around real-world complexity rather than ideal conditions. A practical way to improve reproducibility is a 5-checkpoint approach. First, reach should be secured through sufficient mobilization, including splenic fracture mobilization when indicated. Second, perfusion should be confirmed by clinical assessment of marginal flow and can be complemented by ICG. Third, tension should be assessed within the pelvis. The conduit should lie flat without bowstringing. Fourth, orientation should be confirmed by tracing the mesentery from the abdominal into the pelvis to exclude twist. Fifth, construction should be verified with 2 intact donuts and negative airway test. ICG fluorescence is another tool that can be used to assess perfusion. As the previous speaker has already covered this topic in detail, I will not go into the specific here and we'll just move on. Postoperative pressure control is another supportive measure. Transient decompression tube aim to reduce intraluminal pressure and support healing. Although evidence is variable, the physiology rationale has led to widespread use in some regions. However, this device cannot compensate for inadequate perfusion or excessive tension and require careful handling to avoid complications. Even when construction is technically sound, outcomes depend heavily on early detection of complications. The timing of recognition and prompt intervention often determine whether recovery proceeds smoothly or evolves into chronic disease. Progression to chronic pelvic sepsis is strongly time-dependent. Early clinical signals such as persistent discomfort, fever, or unexpected inflammatory changes should not be overlooked. Imaging findings, particularly persistent extraluminal air beyond the early postoperative period, should prompt immediate evaluation. Early detection preserves the opportunity for effective service. When leak occurs, management typically follows a step-up strategy. Initial priorities include sepsis control and drainage. Small early defects may be amenable to limited closure techniques, but established cavities often require cavity-directed therapy. In unstable cases or when conservative measure fail, surgical intervention becomes necessary. In selected situations, permanent stoma formation may represent the safest option. Endoluminal vacuum therapy aims to prevent chronic cavity formation and preserve the possibility of restoring continuity. It works by gradually collapsing the cavity and promoting granulation. Early initiation improves outcomes, particularly when the cavity is localized and accessible. However, extensive disruption or severe tissue injury limit effectiveness. Stricture formation is another major consequence of ischemia and chronic inflammation. Short membranous strictures may be treated with endoscopic dilation, although repeated sessions are often unnecessary. Longer or fibrotic strictures may require surgical revision. Even after anatomical correction, functional impairment may persist due to loss of reserve compliance. When EVT fails or is not feasible, surgical revision should be considered. A tuberculate delayed coloanal anastomosis is a staged approach that distributes risk over time. The colon is first pulled through and exteriorized about 5 to 10 centimeters beyond the anal bulge without immediate anastomosis. Over 7 to 10 days, pelvic dead space sealed around the colon, reducing pelvic sepsis risk because stump necrosis, if it is occurred, developed outside the body. At day 7 to 10, the ischemic stump is trimmed and coloanal union is complete. This approach can be used in service settings or in very high risk situations, such as irradiated or hostile pelvis as a first surgery. However, it requires managing a hanging colon, carried carries a risk of retraction and it involves two procedures. Redo reconstruction should be considered carefully, focusing not only on feasibility but also on appropriateness. Favorable candidates typically have preserved sphincter function and localized defects. In contrast, patients with severe pelvic damage or poor functional result may benefit more from permanent diversion. Aligning expectations with a realistic outcome is critical. All these elements covers you into three connected domains: quality of life driven design, safe construction, and early rescue. Integrating these domains into a coherent strategy improves consistency and reduces delayed reactions to complications. Clinical decision-making should begin with explicit goal setting. Functional expectations, tissue conditions, and patient priorities must be evaluated together. Standardized construction techniques, supported when necessary by adjunctive tools, should be followed by structured postoperative surveillance. Early intervention when abnormalities appear is essential to preserve long-term function. In summary, the true challenge of chlorine anastomosis lies not only in preventing leakage, but in avoiding the cascade that leads to chronic pelvic sepsis and functional collapse. Safe construction, vigilant monitoring, and timely interventions are all essential. Ultimately, success should be judged by functional recovery and quality of life rather than anatomical continuity alone. Thank you for your attention.